Today, I'd like to focus on peripheral nerve blocks, especially those used in the emergency department during the initial management of acute cases. In modern perioperative care, peripheral nerve blocks have become an essential tool, whether used alongside general anesthesia or even on their own. But what about in the emergency setting? Is it really okay to perform nerve blocks in the emergency department? If we block just because the patient is in pain, we might weaken their muscle strength, and we could lose the ability to assess sensory findings in each nerve distribution. And what about compartment syndrome, common after trauma to the lower leg or forearm? Couldn't we miss it if we rely too much on the block? That's why, when it comes to nerve blocks in the emergency setting, we really need some clear rules. We should choose blocks that don't risk nerve injury. We should set rules to make sure we don't miss compartment syndrome. And we should also have rules to avoid local anesthetic toxicity. That's the idea. So, I've put together a checklist to use before, during, and after the procedure. This one here is the before the block checklist. If the patient is not fully alert, a nerve block may not be safe. An exception might be when severe pain is driving them into delirium. If neurological symptoms are already present in the area to be blocked, it's usually better to avoid the block, otherwise, we can't tell if the symptoms change. For fractures with high risk of compartment syndrome, like tibial or forearm fractures, we need to make sure there's an environment where repeat evaluations can be done. The total dose of local anesthetic must be calculated based on body weight. We hope never to need it, but intralipid should always be available, just in case. Aseptic conditions are essential, proper needles, skin prep, and so on. Standard monitors are usually available in the ER, but they should always be attached so we can catch sudden vital sign changes. And of course, informed consent is required after explaining the risks. Now, this is the during the block checklist. Always keep the needle tip in view. In some hospitals, the whole procedure is even recorded on video for later review. Inject the local anesthetic in small, incremental doses. This helps prevent both toxicity and nerve injury. Always aspirate before injection to make sure you're not in a vessel. If you feel resistance while injecting, stop. If the patient reports paresthesia or pain during injection, stop. The so-called stay away technique is a very important concept here. And always confirm the spread of local anesthetic on ultrasound. If you can't see it, don't keep injecting. Finally, this is the after the block checklist. Reassess the neurological findings and make sure to document them. Keep monitoring for at least 15 to 30 minutes. Pain relief itself can sometimes cause a sudden drop in blood pressure. Before leaving the patient, explain the early symptoms of local anesthetic toxicity. Also, tell the patient to come back if any neurological symptoms remain after the block wears off. And most importantly, document everything: procedure details, drugs used, findings, and what you explain to the patient. Alright, let's move on to the next section. Let's do a quick review of upper limb blocks. We'll go over the brachial plexus blocks as well as the more distal, individual nerve blocks. Brachial plexus blocks are very useful. They can produce wide coverage with only a small amount of local anesthetic. But if we perform them without fully understanding the risks, they can also lead to serious complications. The most important complication to keep in mind is respiratory impairment caused by phrenic nerve palsy. When we perform brachial plexus blocks above the clavicle, the local anesthetic can spread to the nearby phrenic nerve. In the emergency department, we see a wide variety of patients. On average, phrenic nerve palsy reduces respiratory function by about 15%. For a patient on home oxygen therapy, that's definitely not an acceptable complication. So, let's move on to the interscalene block. This is considered one of the simpler Plan A, in regional anesthesia. In trauma and emergency care, it's often used before reducing a shoulder dislocation. Here, I'll show you a flowchart, what to check before performing the interscalene block, and then the actual steps of the block itself. Now, let me explain that stay away technique for the interscalene block. In anesthesia, we often aim for shoulder analgesia by placing the needle between the C5 and C6 roots for the upper trunk. But actually, we don't need to take that risk. Injecting into the middle scalene muscle, just before reaching the roots, can provide identical, excellent analgesia. In the emergency department, our goal is simply pain relief. So, instead of going close to dangerous structures, let's focus on staying safe while still providing effective analgesia. Next, let's look at the axillary approach. This block is used for analgesia from the elbow down to the forearm. It's also considered a Plan A. Ideally, the arm should be abducted to 90 degrees, but in the emergency department, that positioning isn't always easy. I will present the anatomical structures that should be identified in the axilla, along with a flowchart. As shown in the lower right image, could repeatedly moving the needle tip around the artery increase the risk of puncture-related complications? Now, let us look at the axillary stay-away strategy. This means performing only the first needle pass, as shown in this image. The needle tip is advanced just beneath the axillary artery, at the so-called 6 o'clock position. A single periarterial injection at this site provides effective brachial plexus blockade. The local anesthetic deposited deep to the artery spreads into the superficial layers by hydrodissection. Although the musculocutaneous nerve appears to be separated, it actually joins the lateral cord proximally, just like the median nerve. Therefore, the block becomes effective at a slightly different slice than the one shown here. Finally, let us take a look at nerve blocks performed at the forearm. This approach provides very rapid and effective analgesia of the hand. Although nerve blocks can sometimes be more challenging at the distal level, in the mid-forearm each nerve and accompanying artery can usually be well visualized. Proximally, the artery and nerves are more widely separated. While this increases the safety of needle insertion, performing the block proximally tends to cause motor weakness of the hand. At any level, instead of advancing the needle tip directly adjacent to the nerve, inject the local anesthetic into the same intermuscular compartment in which the nerve lies, so that the drug alone spreads to the nerve. Now that we understand how to perform the block, the question is whether we can achieve the optimal patient position in the emergency department. The interscalene block can be performed as long as the neck is visible. However, pressing the probe firmly against the cervical region may sometimes trigger a vasovagal response. If the block is to be performed in a sitting position, it is preferable to have back support. For the axillary block, the probe cannot be applied properly unless the shoulder is abducted. In such cases, it may be necessary to switch to another approach. It has been shown that performing a median nerve block at the proximal level causes dilation of the radial artery. This occurs because sympathetic innervation is mediated via the median nerve. Therefore, performing a block indiscriminately in the acute phase of trauma may lead to rebleeding from areas that had been suppressed by vasoconstriction. Since both arteries and veins dilate maximally, a block should not be performed lightly in situations where hemostasis by compression would be difficult. We have now taken a broad look at various aspects of peripheral nerve blocks. I hope this has highlighted that blocks must always be performed with a wide range of considerations in mind. While we often say, let's perform a block, it is important to remember that this is only one option for achieving analgesia. Ideally, one should be well prepared and gain sufficient experience with safe, surgical anesthesia level blocks before attempting them in the emergency department. But, patients always arrive in the ED unexpectedly. We should therefore be ready to provide safe and comfortable analgesia whenever the situation calls for it.